Director Sir has joined. Professor M.C. Mishra has joined. Professor Venkatraman has joined. Dr. Sandeep Bhatia has joined. Major General Atul Kotwal Sir has joined.
Dr. Bagga, I too have joined. I'm Srinath Reddy here.
Professor Srinath Reddy also has joined.
Good afternoon, Professor Srinath, sir.
Thank you. I just wanted to make sure that I'm properly connected.
Yes,
I think
sir.
I am. Thank you.
Yes, sir.
Ma'am, we are live now. We can start.
Yes, yes. Good afternoon, everyone. We are so happy to have you back with us. Before we go further, I will request our director, Professor Harsha Thakur sir, to please welcome our eminent speakers and our chief guests. Professor Harsha Thakur sir.
Okay, thank you, Professor Bagga madam, and good afternoon, everyone. I welcome all the dignitaries on the virtual dais. I also welcome all the participants from all over India. And actually, I thought madam will first give some brief introduction, but I think she has left that job to me. So anyway, last year during December 3 and 4, 2020, we conducted HRH Human Resources for Health Symposium, and it was a huge success. We had more than 2,000 participants, and that time it was an unexpected sort of thing. We never thought we will get such a huge response, but that time we realized that HRH is a big issue, and we need to focus on that. So based on that symposium, we identified 7 areas which are very crucial to achieve universal health coverage. And then we had a lot of brainstorming. We also came out with a book on the HRS symposium. I think Professor Bagga will be releasing it shortly. And we also thought that we can use this webinar to release it, and we can call eminent speakers who will also panelist and chairperson during that particular webinar symposium. So we can invite them, and we can have a group discussion to identify what can be the way ahead. So all these 7 areas are already highlighted, given in the brochure. And I think I will not take much of your time. I leave it to Professor Bagga to go ahead, because we have a lot of eminent speakers. I think I will like to hear them rather than hearing me again and again. So once again, I congratulate Professor Bagga madam and her team to successfully conducting our virtual symposium, coming out with a very good report, which we circulated everywhere. Also, I will like to thank WHO and UNICEF and other stakeholders for their active participation. And I think Professor Bagga madam, please go ahead.
Yes, thank you, sir. Thank you for your support always, sir. It is because of your leadership we were able to hold this symposium at NHFW. I would now like to request our 2 Sutradhar for this webinar. My highly capable team members, my colleague Dr. Vandana Bhattacharya, and our upcoming bright public health professional, Dr. Ruchi, to please run this program, and first of all, introduce our chief guest and guest of honor. Yes, Dr. Ruchi and Dr. Vandana.
Thank you so much, ma'am. Good afternoon and a very warm welcome to everybody once again. Greetings from NIHFW. It is my privilege to introduce you all to our chief guest of this evening, Major General Professor Atul Kotwal, the Executive Director, NHSRC Delhi. He has 30 years of experience as a specialist in planning, monitoring, implementing, and evaluating various health programs at national and international level. He has made major contribution towards improving health, hygiene, and sanitation in the hospitals of armed forces. He is involved in administration of health units and cantonment general hospitals as a specialist and is also serving as advisor public health, Government of Botswana for 3 years. He is also member of various committees dealing with planning healthcare activities and initiatives and research. Sir, I request you to give your inaugural address. So over to you.
Yeah, thank you, Dr. Ruchi. And my humble request to, good afternoon, everyone. Humble request to everyone that please don't consider me as a guest. They're very esteemed panelists and experts there in front of them. I don't think I
please unmute yourself.
Chief guest. You can't hear me?
I can hear you.
Can you hear me now, sir?
We can hear you, sir. Yes.
Yes, sir.
Okay, so good afternoon, everyone. And thank you, everyone, for giving me this opportunity. But my request is that please don't consider me as a chief guest or guest in front of the luminaries and experts who will be speaking later. To consider me as one of the participants out of 185 participants who are already there in this webinar. And it's just that I've got the opportunity to speak before the experts. And thank you for that. And at the outset, I would like to congratulate Dr. Harshad Thakur and his entire team, especially Dr. Rajni Bagga, who's coordinator also of the webinar, and all the esteemed panelists and attendees. Actually, the panelists, again, because you held a webinar in December 2020, and this dissemination is based on that. And that webinar, which was aligned to the global strategy of HRH, that was extremely, I think, timely, as the COVID pandemic has highlighted the renewed focus on HRH strategies which are required not only in our country, but in the entire world. And despite all the challenges which are continuing, our healthcare workers at frontline as well as in the facilities are continuing to be at the forefront of the fight, saving millions while putting their own lives at risk. And to put this HRH in perspective, even before the pandemic, the country had realized that to achieve universal health coverage, a strong and robust health workforce is required. The spirit of UHC, as you all are aware, is enshrined in the goal of National Health Mission and also reiterated through the National Health Policy 2017. So India has moved ahead on strengthening HRH by catalyzing NHM and the NHP 2017. So the symposium last year, just to recap for the participants who joined in probably for the first time, the dissemination webinar, encircled certain specific challenges on HRH leadership, governance, strengthening, nurturing and midwifery, transformative education for health sector in India, just to highlight a few. And with active participation from India and all the other and the globe, the platform provided an opportunity for the academia and stakeholders and experts to discuss these issues and bring out possible solutions and strategies to strengthen HR. And I have seen the proceedings, very enlightening, and I learned a lot while going through those proceedings. And thank you very much for all the experts who were there in that. So and I think very aptly that the dissemination webinar has been organized for mutual learning and to come together once again to synthesize and use as evidence to draw strategies for way forward, so that we deal with the HRH challenges to emerge with a strong public health workforce. We can get enough adequate funds if funds are available, get the infrastructure, the equipment, the drugs and diagnostics, everything. But the human resources is something which we can't produce overnight. The government announced the ECRP proposal yesterday, so we may be able to achieve whatever was announced in the infrastructure part, but the human resources is where, which is a major issue. And though I would not like to stand between the participants and the experts, but just to touch a few of the issues which the symposium highlighted, and just I think they need to be reiterated. So I would start firstly with the professional and personal rights of the healthcare workforce. That while as planners and also implementers, we must look at these issues also. We must provide an enabling environment with defined support structures to ensure their safety and security and dignity. So that we have an overall motivated healthcare workforce. That motivation somehow while dealing with the HRH, we somehow I don't know, it goes on the back burner because there are shortages, there are skill gaps. So we generally discuss all those. So these are the issues, and that's where to reiterate that the leadership and governance are the healthcare human resource for health in our country. Are they getting the leadership and governance they deserve? So we all need to work towards that. Starting from very beginning, maybe along with the training, also have inculcate some leadership habits so that when they become come into the planner level or implementer or the higher manager level, they also should have the leadership qualities, which affects definitely the governance and also the entire human resources management system. So that's why the perceptions and the aspirations of HRH. You all are aware, National Policy 2017 has clearly enunciated creation of a public health management cadre, which is slightly different from what the committee headed by Dr. Srinath Reddy sir had recommended, the public health cadre. But in any case, this also provides us with various opportunities now. And while formalizing this public health management cadre, we must ensure that each and every profession, each and every cadre must have a defined career progression with an assured career progression at least up to a certain level. So while designing this PHMC and implementing it, we must look into it. And it is at an advanced stage of discussion. Various meetings have been held, but we are trying to ensure that these things are inbuilt before we go to the states. Other crucial challenges I think you all have discussed earlier: the shortages, the maldistribution, urban-rural, intrastate, the interstate, the skill gap. They all need to be addressed. An interesting thing which has happened in 2 or 3 years ago is the comprehensive primary healthcare launch in the entire country, with the target of 150,000 health and wellness centers by December 22. So this has created another leadership position at the grassroots level of sub-health center, that is the CHO, the community health officer, mid-level health provider. It has provided the opportunity for the nursing cadre and also the Ayush people with requisite training. They can become leaders of their team. This is another leadership aspect which you need to nurture for other streams also. At the same time, recently, to correct the gender issues, we have also, the government has also looked at the recreation of the multipurpose worker mail card, which was there earlier, but in 2012, the support to the states was discontinued, and somehow this cadre has been reducing since then. Though we have 60,000 MPWs right now, male, but it has to be one per sub-health center. So this is another thing, interesting development which has happened. The nursing and midwifery, last year was the year of nurses and midwifery, but the perceptions of the other healthcare workers in the system and also the community towards them needs to be addressed immediately. I'll share with you, we have one of our partners, I won't name the institution, the study on, I won't share the details with you, but one of the questions in their questionnaire when it came to us for final vetting in the after the tools were being formalized, was that was the dress of the nursing staff appropriate? So that was immediately flagged by us that sorry, you cannot answer such questions. So this was coming from faculty of reputed institutions. So we need to address this issue very, very urgently, and so that they are integrated. They are integrated part. We cannot run any healthcare institution without the nurses and midwifery. But these perceptions which come from the patriarchal society as such, and lack of addressing it in the education system from very beginning, these also need to be addressed so that we have a teamwork and a cohesive teamwork with multi-sectoral coordination also. Another issue I would like to highlight is the task shifting and task sharing. I'm part of one of the EGs, and what we are deliberating right now is that it's time that we, approach the government for task shifting and task sharing in a formal manner. It has been happening, but once we formalize it, there are certificate courses where task shifting can be there, and task sharing in a team-based approach that needs to be ensured at each and every facility level. Towards the end, I would just like to reiterate that along with all of us sitting here, we need to listen to the voices from the field. We need some grounded research to identify the issues faced by them, and also to identify the good practices and innovative approaches which have been used by everyone. I once again would like to congratulate the organizers for conceptualizing even the previous seminar in 20, and also this webinar and organizing it right now. I'm looking forward to listening to all the experts in the field, and I thank the organizers for giving me this opportunity of speaking before the experts. Thank you very much. I wish you all the very best.
Thank you so much, sir, for your insightful words. Strong and robust health workforce is required for achieving universal health coverage. And sir has rightly said that leadership, transformative education is important for a robust health workforce. So now moving forward, now I would like to introduce to our guest of honor for today's webinar, Luigi Daquino. He is the Chief of Health at UNICEF India. He is also serving as the COVID-19 Response Coordinator for UNICEF India office. He has been working for 20 years in global health policies, and health system strengthening in various countries in Africa and Asia. He has also worked at the Liverpool School of Tropical Medicine, at UNICEF Mozambique, at Save the Children, at Medicine Sans Frontiers, and with other organizations. He strongly believes in partnership as a critical force for change. I would like to invite Luigi to speak a few words. Luigi?
Thank you very much. Good afternoon, everyone. Glad to be here. First things first, Dr. Ruchi, you pronounced my name and surname perfectly. So well done. Congratulations. It's not straightforward. Also, I wanted to say pleasure to finally meet you, at least see you on screen, Professor Kotwal. I'm in an even worse situation than you, because you were between the speakers and the experts, and now I am between you and the experts. So I will try to be as short as possible. I'm here really to listen and to learn. As it happened in December, it was an amazing workshop. The report crafts everything very clearly. Before I share my few or 2 cents, I wanted to share this bad news that I heard the other day, that this is the last official event which Professor Rajini joins at NHFW. After 31 years of service, I think time has come to move. Professor Rajini, what can I say? I've only been around for 2 years of this long journey, but it's been enough to learn and to learn to appreciate you as a professional and as an individual. So best wishes, and please don't forget us. Whatever comes next, we are all here and happy to still interact with you. Sorry, I couldn't resist from doing this. What better way to spend a Friday afternoon to hear about healthcare workers as the critical force for universal health coverage? We clearly need all the ingredients in the health system to achieve UHC. But there is one that really is the essential, and that is the human resources for health. We have probably known this for long, negated this for long, globally, internationally, underestimating the issue. And I think we have seen it as strongly as we could since the onset of COVID-19. And really each and every of the healthcare professionals deserve every single day a huge word of thanks for all what they've been doing and risking and sacrificing for helping the broader community in these tremendous times. Yet, let's park COVID for a minute. I was back at a systematic review published by the British Medical Journal a few years back, I think 2017, across the 69 countries. And what came out of that systematic reviews comes with advantages and limitations, but still, that a public health professional in India could spare 2.5 minutes per patient in the public sector. This is the level of, at least this is one piece of evidence of the workload. Now, if I look at the baby behind me as my ultimate goal, aspiration, and dream, that each and every of the 30 million pregnancies that this country sees every year see a healthy mother and a healthy child growing and developing clearly, we need a workforce that has the time, the competencies, the environment, the space, the motivation, the dedication to deliver high quality services to all those in need. I was moving around and trying to look outside of the health sector, and at times you realize that how many common denominators we have. There is another interesting survey published by the Boston Consulting Group. So they went a few years ago interviewing about 200,000 professionals, any sector. It could be any of us or anyone else, asking what are the top factors for job satisfaction. And as simple as such, what comes out is appreciation for work, good relationships with colleagues, work-life balance, good relationship with superiors, learning and career development, job security, a decent fixed salary, an interesting job content, and the values in the work environment. And as I read this, I think that the seminar, the workshop, the discussions of today that are framed around these 7 pillars that stem from those 4 big areas of reflection of the December workshop are really looking at a lot of these issues. An enabling environment that from every perspective and over a long term, because things cannot be done over a day when it comes to creating capacity, can put the healthcare providers in every corner of this country in the best position to deliver the job that they are passionate about and they are willing to do. I would just spare 2 final thoughts before wishing all the best and then listening to the experts, the real ones, not me. One is equity. It's always easy to think of healthcare workers in a clinic, in any setting. We need to look beyond the usual in the remote areas. The minimum conditions need to be met everywhere. And it's not easy for the little I could travel in India before the pandemic to think how a healthcare professional could make it in some of the very remote communities of the country. And yet this needs to happen. And I think this needs to be a direction of travel. It speaks to UHC. If we don't look at this, we set ourselves to fail. The second is gender. We know that a lot of healthcare professionals are women, and we know how much they are carrying on their shoulders, not only within the profession, but also within their families and their communities. again, if we think of a strong health workforce, we cannot underestimate the gender dimension. If I only think of the ushers, it's an army, and they are women, and they need to take care of families, of kids, of communities, and of their work. So we need to look at policies and an enabling environment that takes into account the aspect of gender. My third and last plea is that, and it's my humble belief, right or wrong, there is no evidence to that, it's just my thinking. In these days where we are, even the best scientist, doctor, professional that goes out there in a facility or in a community to deliver care cannot only be an excellent health professional. In these days, the person needs to be a manager as well, a leader as well, a communicator. We need healthcare workers who can understand management, can understand data, understand communication, and understand governance. Without that, we are not creating the workforce that I think is what is needed going forward to make yet another shift in the amazing journey that India has been making over the past decades in moving towards SDGs. I would close it here, and thanks, it took long, but I can now finally hand it over back to you.
Thank you, sir. Thank you so much. We are really grateful to you for the time and efforts you took for sharing your thoughts and enriching experience. Thank you so much, sir. A small reminder that this webinar is streaming live on YouTube also. So the link has been shared with you all for that in the invitation email which we have sent you across. It has been more than 1.5 years when we started this journey of building the importance of human resources for health in India. Today, globally, there is much more realization than before that for achieving universal health coverage and SDG goals, it is the HRH which needs much more strengthening. So now I invite Dr. Rajni Bagga to take us through this 1.5-year journey and give us the key highlights of the HRH report and objectives of the webinar. To you, ma'am.
Thank you so much, Dr. Vandana, and thank you so much, our chief guest, Major General Kotwal, and our guest of honor, Mr. Luigi, for delivering a very, very important and pertinent your address, inaugural address. Now, I'm very happy to have all of you back with us to celebrate the report of our symposium and our way forward. I would like to share that this has been an immensely overwhelming 1.5-year journey for us when we started thinking about that we have to do a lot of advocacy about strengthening HRH in India. There is a consensus globally that proper management of HR is critical in providing high quality of healthcare. In order to achieve the UHC and SDGs, equitable access to the skilled and motivated health worker within the performing health system needs to be ensured. WHO has been extensively focusing on the importance of HRH for strengthening the health system and the global strategy on human resources for health workforce 2030, published in 2016. Health system can only operate with the health workforce. Improving health services coverage outcome is dependent on availability, accessibility, and affordability, and the quality. And with this genesis in our background and our own enthusiasm, we started this journey. And the first event in this journey was that we held a one-day national brainstorming workshop because we wanted to bring all the eminent experts from India and the public health and management professionals to help us to deliberate and to arrive at a consensus for the objectives and the agenda and themes for this workshop. And friends, I'm very happy to share that this workshop was very successful, and the intense group works and discussions which were held during this group work, and we got immense support from WHO, from UNICEF, from Niti Aayog, from Ministry of Health and Family Welfare, from DGAFMS, and this helped us to arrive and have a consensus that the conference that we are aiming to have should focus on the 4 things. The first one, the HRH challenges. What are the challenges for human resources in health? What are the issues related with governance, leadership, and management for building HR in India? Strengthening nursing and midwifery services for enhancing health coverage in India. And last but not the least, transformative education for health sector in India. And with this report of this brainstorming workshop, we started preparing. We went ahead preparing for a 3-day conference in December from 3rd to 5th. And we got resounding support and partnership from WHO and UNICEF to help us to organize this event. But friends, living with the challenges of the COVID-19 pandemic, the initially envisaged HRH conference was transformed into a virtual symposium with the broad thrust to advance the implementation of global strategy on HR. And the vision for this symposium was to optimize the existing health workforce in pursuit of the SDG and universal health coverage, and to shape the HRH practices reality with support from WHO, UNICEF, Niti Aayog, and from our Ministry of Health and Family Welfare. And the main highlights of this 2-day event, 3rd and 4th December, the symposium was aimed at the wider audience that we got were the policymakers, the planners, practitioners, including those from public, private, and civil society, academia, and researchers. We had more than 2,000 participants globally. Eminent speakers, highly distinguished public health and management speakers delivered the keynote addresses. Various themes were presented by the expert speakers across the globe. We had participants' comments were continuously buzzing. The chat box was a very interesting window to have a glance at the views and voices of our participants. And this helped us to bring about a very, very comprehensive report. And this report, friends, which was developed by my dedicated team, focused on listening to each and every speaker's presentation very keenly, looking into the comments coming, the discussions which were held, and the questions and comments of our participants. We were happy to develop this report. We have shared the hard copy with our eminent speakers, and we have sent the soft copy to almost all the participants. And friends, when we were developing this report, we came to an understanding, oh my goodness, there is a lot of critical analysis data in front of us. We are not just going to report that who said what. We are going to come down the critical analysis that all these comments lead to what. So we together sitting on a table, we 4 of us, we drew an umbrella, a symbolic of universal health coverage. And under this umbrella, we said there are 7 loud themes and agendas which need to be taken up in India at the policy level, and if we have to go forward. Friends, in this direction, our first agenda, the theme under this umbrella is, most of the people said we need an HRH policy at the central and at the state level. Do we have an HR policy? Sorry, we don't have. We need to have a robust HR policy, and COVID pandemic has drawn this realization much more. Followed with this, everybody said over the 2 days, we need HR units, a dedicated HR units managed by the professionals, both at the central ministry and each and every state directorate should have HR unit, which will do HR mapping, which will do HR visualization, which will do skill building. Like Professor Kotwal, Major General Kotwal talked about multi-skilling and task shifting. So these HR units have to work on how and where and with which professionals we had to focus on task shifting. And wherever task shifting has happened, it has brought about sustainable outcome results. And the next in line, over the 2 days, there was unanimity consensus, strengthening leadership, leadership, leadership. As we all know, our health sector is over-administered and under-led. Today, we need leadership to build vision. We need leadership for sustainable change. We need leadership to build the people, to build the organizational culture. And we have our most distinguished speaker, Professor Srinath Reddy, to deliver the address on strengthening leadership today. And the next was, we don't have nursing and midwifery directorate, except West Bengal and 1 or 2 places. We need to have dedicated directorates at the central and state level, which takes care of building this rich human resource. 90% of our healthcare, maternal healthcare, is delivered by the nursing and midwifery workforce. We have to focus on their upskilling. We have to focus on their performance appraisal, on their career graph. And next, this cannot happen without having nursing and midwifery leadership. We have to bring up the nursing and midwifery leaders at the same level at the policy decision making. We need to have a horizontal structure, not a vertical structure for policy level decision making. And friends, we had a very good discussion on 4th December about reforms that we need in the education system. And the mantra which came up during this discussion was the education system to increase employability. So this is going to be focus, and we cannot have a better speaker than Professor MC Mishra, the former director of AIMS, to speak and address on bringing about reforms in the education system in the health sector. And last but not the least, friends, everyone were voicing, what about the safe and secure environment for health workforce? We are seeing in the last 5, 6, 7 years increased violence against our healthcare provider. It happened so much during the COVID-19 pandemic. And these health workforce was our warriors. They were helping us to sustain through this unprecedented circumstances. But what about their mental health issues? There has been increased burnout, psychosocial stress among these healthcare providers. So what are the ways to develop the policy level changes and the institutional level reforms to bring up the safe and secure environment? So friends, these are the 7 endorsement action agendas that came up during our critical analysis of building this report. And today's webinar is based to address that how do we go forward. Our report focused on the way forward. This symposium was the first of its kind endeavor in India with thrust on HRH, and several speakers viewed this as an opportunity for policymakers, planners, practitioners to deliberate on challenges and possible solutions for optimizing the human resources. The resounding response of this first event, it calls for the need to convert this as an annual event in India for continuous dialogue and maintain. The first symposium has raised the need for making a council a body of association of HRH. Only then we can make it an annual event with regular advocacy. The symposium helped in identifying huge potential for application of best or replicable practices for bringing reforms at the governance level in the health sector, be it state directorates, the service delivery, the educational institution, or the regulatory bodies. The future event should have active participation presentations by the state health agencies. The symposium identified the need for networking for potential collaboration and partnership with various agencies. And with this, friends, I thank you all to connecting back with us, and we have a long way to go. And this is on behalf of my very dedicated and sincere team of Dr. Vandana Bhattacharya, Dr. Monica, and Dr. Ruchi. And now over to you, Dr. Ruchi.
Thank you, ma'am, for taking us through this journey of HRH initiative at NIHFW. So now we'll start with our program by listening to each of our speakers on each theme. And if time permits, we can take few questions. You can submit your queries throughout the webinar in the Q&A section. So without any delay, let us move forward to our first theme, that is strengthening leadership for H agenda. And who better than Professor K. Srinath Reddy to address this key theme. Professor Reddy is a Padma Bhushan awardee, currently the president of PHFI and simultaneously serving as an adjunct professor of epidemiology at Harvard. 5 IIPH have been established under his leadership. He is the first Indian to be elected to the National Academy of Medicine, USA. He is also the former HOD cardiology at AIIMS Delhi and also the former president of World Heart Federation. Professor Reddy, over to you, sir.
Thank you very much. I'm grateful for all the partners who have initiated the second meeting to advance the HRH agenda in the country.
Professor Reddy.
Yes? You can't hear me?
Elvin.
Yes,
I'm
sir,
not muted.
You're audible, sir.
Yes.
Yeah, okay. I said I'm grateful to all the partners for having initiated this excellent second symposium to continue the agenda that was crafted so well at the first symposium. And I'm grateful also for the opportunity to speak. The issue of leadership has already been touched upon in all the preceding talks. But I believe it is important for us to consider how leadership in HRH is absolutely essential for universal health coverage, because that leadership is embedded in the capacity, competence, and connectivity of the health system's human resources to deliver upon all the objectives of universal health coverage. As has been emphasized already, we need leadership at individual, team, institutional levels, but also at the level of networks and multi-sectoral collaborative partnerships. We need leadership for engagements within and outside of the health sector. And as Dr. Kotwal has very aptly reminded us, this is a very opportune moment to examine the issue of human resources and health as an essential component, indeed a necessary component, not just a sufficient component of universal health coverage. Because we have seen that the COVID emergency response package that was announced yesterday, amounts to about 23,123 crores. It talks about pediatric units in all 736 districts. It envisages pediatric centers of excellence in all states. It talks about increasing testing facilities, also genomic analysis for surveillance. It talks about health management information systems in all district hospitals. But we need human resources for all of this. Health system does not function only on infrastructure and supplies, essential as they are. It is the human resources that will have to utilize the infrastructure, manage the supplies, and ultimately use both for delivering the essential services that are needed as a part of UHC. In addition to what COVID has called upon us to do, we have the full agenda of sustainable development goals, all the objectives envisaged in the National Health Policy of 2017. And of course, UHC is very common to both of them and indeed forms the platform for many of them. We also need to look at the whole issue of public health cadres. Professor Kotwal mentioned that the high-level expert group, which I happened to lead in 2011, talked about public health cadres, while the National Health Policy talks about public health management cadres. Indeed, our report of 2011 did ask for public health cadres as well as health management cadres, but their fusion into a public health management cadre is also very welcome. So we did recognize the importance of the management skills as well, even in our 2011 report. We also recognize that the urban health mission, which has not yet taken off, but is absolutely important, needs to be strengthened, not yet taken off, at least in full form. And what if COVID-19 has taught us anything, that urban primary health care is absolutely pivotal for delivering a variety of services, whether it is initial early detection of cases based on symptoms, followed by prompt testing, contact tracing, arrangements for home care or transfer to hospital as needed, ensuring there is adequate prevention and COVID-appropriate behavior, whether it is looking at how best we can actually bolster vaccine confidence, counter myths and prejudices and stigma. Every one of these is dependent upon a very well-structured and well-functioning primary healthcare team. Yet, urban health mission has been very slow to evolve, and this time COVID has reminded us that we'll pay a price if we continue to neglect it and only focus on advanced care institutions and ventilators. The need for human resources in health is very huge, and we need leadership to advance this effort, to ensure that we not only inculcate leadership among the human resources that we have, but in order to expand and enhance the skills of the health workforce to a much larger dimension, we require leadership to push that effort forward. So we have to make the argument that the health workforce is pivotal. And it's very clear. We need leadership for creating capacity for identifying and meeting the needs of a wide array of health services to meet the many health needs of the people. We need leadership for enhancing the quality of healthcare. In my mind, quality of health services has to answer 4 questions, 4 attributes. Is it beneficial, the service that we are rendering? Is it safe? Is it resource optimizing, both in terms of optimal utility of finances and human resources? And does it provide satisfaction to the patient, to the family, and to the care providers? Because the care providers too need to be working in a satisfying environment, which is safe and also giving them the level of work satisfaction they need, with adequate, appropriate equipment, without stockouts, with good working conditions. All of that is also required, as has already been stated. Then the question is, we also need leadership for opening up of opportunities for persons in training as they complete their education. Where do they enter the formal health workforce? Private, public sector, how do they actually ensure that the skills and competencies that they've acquired are appropriately utilized? We need leadership for improving service conditions, leadership for efficient cadre design and cadre management, for promoting interprofessional education. If we want nurse practitioners to be developed, or we want other professions to have interlaced competencies? How do we actually manage that on platforms of interprofessional education? For enhancing the ability to use health technology competently and comfortably, efficiently and economically. Again, we need to build those skills which are part of that leadership. For team building at each level of care, we need to instill leadership skills for the team leaders as well as the people in the team who will eventually graduate to become team leaders. For smooth coordination between different levels of care, we need leadership. For HRH mapping and monitoring for gaps and asymmetry of distribution. Again, that's an important leadership attribute to find out what needs to be done to fill the deficiencies. For program management skills, for policy engagement skills, for engaging with other sectors relevant to health, because universal health coverage is not locked only into the health system. It requires multi-sectoral engagement at various levels. So how do the leaders in the HRH engage with other sectors? Again, with confidence and the ability to get the results they desire. For resource optimization, recognizing that our fiscal as well as human resources are limited and they will continue to be limited for some time. How do we best manage our resources? That again requires leadership. So leadership will require analytic skills, operational skills. It also requires a certain degree of emotional skills, emotional intelligence, a temperament, which is also not only willing to partner, willing to engage with others, but also readiness for course correction, that degree of confidence to move forward when the decision appears right, but also the humility to accept that things may have gone wrong and course correct when needed. All of these are part and parcel of leadership that must be developed within the human resources for health. And even as we develop our own leadership skills continually over our professional careers, we need to foster leadership abilities in our younger colleagues who are now currently in the formative phase of their development. And we need to ensure that they are constant learners, because the health system is a complex adaptive system. There are so many things that are changing in terms of the disease profiles, in terms of health system resources, in terms of technologies. Very many new challenges appear almost on a regular basis. So it cannot be a static system. It has to be a complex adaptive system. And therefore, to recognize change and to respond appropriately is a quality of leadership that people who are engaged within the health system, the human resources for health, must develop. Now the question is, Dr. Kotwal said we must be both good managers and good leaders. I entirely agree. We must develop both good managers and good leaders. It has been said that good managers are those who enable you to do things better. Good leaders are those who enable you to do better things. So we need both competencies. When you take up a job, you have to do it well and do it better than it could have been done without a certain amount of skill and commitment. But you also ought to be able to innovate and do better things. And therefore, you emerge as a good leader from being a good manager. And these are important elements that we need to build in. So we need to build both skill sets in our younger colleagues as we mentor them. But one of the elements is we must really emphasize is the need, as Dr. Kotwal said, voices from the field, they are important. In fact, as we are team building, as we're building partnerships, participatory leadership is absolutely important. No longer is the top-down paternalistic model of leadership is valid. You need a certain degree of collective decision-making. Of course, ultimately, leaders will have to steer the way, but participatory leadership gives everybody an opportunity to contribute to their full potential. And therefore, it has to be a consultative process of evolving decisions and then having a committed execution. As has been said, I think, by one of the armies internationally, in that army, they have the motto that they practice debate and dissent in planning. but discipline in execution. And that is the kind of leadership that we must evolve, where we are willing to be questioned and corrected during the debate initially when we are planning. But then the whole team comes together in a disciplined manner once we have accepted what needs to be done as a collective commitment. We must also build coalitions and partnerships. There's a difference between a coalition and a partnership. Coalition brings together different organizations with convergent interests, but who will act on their own to achieve the objectives which will ultimately take us towards the goal. But partnerships are where we also work together, function together, and act together on a particular piece of work and collectively deliver it. So we do need to build coalitions and we need to develop partnerships. And we definitely need to advance the agenda by exhibiting leadership in doing both. Finally, a collective call for action to advance the HRH agenda, because the HRH agenda has remained somewhat neglected over the years. And whether if it is infrastructure supplies that attract attention of the political leadership, whether at the center or the states, it is the human resources for health who will ultimately be blamed for failure if the health services are inadequate. And we have seen that happen time and again when, unfortunately, people question the people at the forefront, whether it's the doctors or the nurses or the technicians in a hospital, for the failures if, for example, oxygen is not available or essential supplies are not available. So we need to ensure that while the other things improve, the human resources for health also receive the attention, and we need to develop their numbers as well as skills and efficiently deploy them. And for that, we have to make a case. And for that, this collective that is gathering today must exhibit the leadership. We need to, in order to achieve those objectives, we need to assemble allies, adopt an agreed agenda, amplify advocacy, accelerate action, and assert accountability. And therefore, this conclave should show the path and set the pace. Thank you very much.
Thank you, sir. Thank you so much for underlining the importance of leadership at individual, institutional, and multi-sectoral level. As you have rightly said, sir, that HR is critically responsible, crucially responsible for delivering essential services for achieving the mandate of UHC. Sir, I'm sure that the participants have been greatly benefited by your enlightening words. We are grateful to you for your for giving us your time and efforts you took for sharing your thoughts and experiences, sir. Now we move forward to our next theme, that is HR policy at central and state level, which will be taken by Professor Venkat Raman. He is a professor at Faculty of Management Studies, University of Delhi. He is actively engaged in advisory work with development partners in Asia, Africa, and Eastern Mediterranean region. Currently a member of a global advisory group on private sector, governance, and UHC at WHO, Geneva. One of the major focused research areas include public-private partnership to improve equitable access to healthcare services for the poor. Additionally, serving as chairperson, National Technical Working Group on Private Sector Engagement in TB Elimination. So over to you, sir. Professor Venkat Raman.
Thank you, Ruchi. Thank you, Dr. Ruchi, and thank you so much to NIHFW, Professor Thakur and Professor Rajni. You have conceived a wonderful symposium, a global symposium, very well received. I can see that from a wonderfully synthesized report also. It was one of the long-standing demand for many of our researchers in the research community in terms of having consultation and a wider understanding and a wider knowledge sharing about various aspects of HRH. And also, I would like to felicitate Dr. Rajni for your more than 3 decades of service to NIHFW. So warm felicitations, and hope you do very well in the future too. If there is a presentation that you can share it with the people, that's all right. Otherwise, I can go ahead with it. There isn't any need to emphasize the importance of a policy. I will restrict my comments primarily on HRH policy. And therefore, to begin with, policy is a statement of intent and a commitment and the way for future directions. It provides a kind of a vision or principles and priorities or objectives and implementation framework, including an institutional arrangement. Most HRH policies are either embedded within the national health policies, either globally, or there are separate ones. Now, for example, in India, it is part of a national health plan policy. There is close to 3 pages of a space devoted to it. And there are some African countries which have separate HRH policies, at least about a dozen of them that I can think about. Second, the HRH policy intent in India is not new. It's been there for a long, it shares a long history, starting from Bore Committee to Bajaj Committee, even the National Commission on Macroeconomics and Health, HLEG, and the latest is the National Health Policy of 2017. If you look at the Bajaj Committee, many of the recommendations are still contemporary in nature. For example, there is a competency-based curriculum, career structure to all health cadres, uniform pay scales, dedicated HRH cells for both the states and at the center, formulation of a national health workforce policy, uniform guidelines for recruitment, preparation of job description. There are many other recommendations that are still contemporary, and we still haven't had much of a progress in that. However, it's a kind of a puzzle as to why we are unable to implement many of these policy objectives. Are these policy intent in the past, are they not comprehensive enough? Are they not based on any systematic situational analysis? Are there any institutional and organizational limitations in implementing these policy intent? Is there a problem of political commitment or a bureaucratic commitment to change? Are there legal and regulatory bottlenecks towards implementing some of these policy intent? Are there issues of HRH leadership and stewardship? Many more questions come to one's mind, but apparently almost all these questions or reasons seem to be true, because wherever you turn, there is an element of a barrier or a bottleneck. Let's look at, just to illustrate, let's look at the HRH policy component under NHP 2017. Can you go to the next slide, please? There is a significant section of national health policy is devoted to HRH. Nearly 3 pages out of 25 pages. If you remove many pages, it would come down to just about 15 to 20 pages of a national health policy, out of which 3 pages have been devoted to HRH. What does this HRH intent policy statement mention? The policy statement gives a key principle towards HRH. Within quote, I am putting this: workforce performance of the system would be best when we have the most appropriate person in terms of both skill and motivation for the right job in the right place, working within the right professional incentive environment. Now, if you look at the 9 components that are explained in the National Health Policy, 6 out of 9 of them statements focus on training or education of medical, nursing, paramedical professionals. And therefore, if you look at it, the reason why I highlighted skill as in the red, the rest of the key principles seem to be somehow disconnected. Now, besides the 6 points on education, training, and an overemphasis on education, skills development, and training, imagine a policy statement also provides a statement on the need for a multiple choice test for entrance exam. That's a kind of a statement that somehow innocuously crept into this NHP document. Even under the HR governance and leadership, it still focuses on CME and skill development. There are 3 points which mention about attracting and retaining doctors and specialists. It speaks only about the doctors and specialists, not more than that. Cadre of mid-level service providers and infusion of public health management cadre. This already had been spoken, and therefore I'll not revisit that particular part. It looks as if this particular 9 different components mentioned in NHP policies, there is a disconnect between the overall vision and the objectives. How are these? Are there any pathways that link the HRH statements here in the NHP and the overall health policy objectives to be achieved? There isn't any kind of pathways that are initiated there. But why such a statement on HRH should focus only on the public health staff, I still do not understand. Shouldn't the HRH policy be for health sector as a whole, irrespective of whether they are in public, private, or not-for-profit sectors? For example, if I were to draft a vision for an HRH policy document, and if that vision states something like safe, fair, professionally rewarding workplaces, shouldn't this include for all health staff? For example, violence against healthcare providers or workplace safety, after all, cuts across all. And the causes for violence at workplace towards healthcare providers could be organizational factors such as workload, understaffing, etc. So if an HRH policy envisions a safe workplace, then the pathways of that, if you work backwards, it talks about staffing norms, it talks about management guidelines, it talks about implementation framework, and the law to prevent and punish the violators can come into play. What is happening currently is that there is a knee-jerk response from the government to promulgate a law when it comes to violence against healthcare providers. But if you did have a health policy, HRH policy, which envisions a safe and violence-free workplace, you would already have some foundations on which such kind of a policy could be, strategized. So you tend to react to each one of these situations according to the demand arising out of day-to-day requirements. And therefore, an HRH policy needs to have that kind of a vision to provide a overarching and a very comprehensive understanding of the human resource management or human resource in health sector related concerns and organizational issues. So HRH policy therefore should not only focus on supply side responses such as education, training, skill development, posting, retention, or incentives and cadre creation, which tend to look at HRH as an extension of production function alone. Therefore, it is equally important to take into account some of the organizational and work-related dimensions and not brush aside such kind of issues as a civil services or personal administration issues. So let me now focus on the HRH policy. Can I go to the next one, please? HRH policy usually includes 4 major components. This is globally what we see, both in terms of the WHO document of 2030 vision document, as well as some of the sample HRH policy from Africa that one had seen. One is supply side planning according to norms or job categories or deployment needs. The second policy statement it talks about usually education, training, and competency development, including the production and the development of skills or human resources. The third element usually is service delivery performance, including work organization, roles and responsibilities, coordination, professional standards, quality, efficiency, etc. The fourth component usually are working conditions, including organizational issues, human resource management subsystems, so as to attract, motivate, and retain productive workforce and adopt contemporary management practices. Usually, all HRH policies tend to focus on these four dimensions. But in recent years, there has been so much of a change in the way that HRH and the organizational system, health service delivery systems have changed. I dare say that HRH policy, to be more comprehensive, we must recognize and include the following items also, or following perspectives also. Number one, health system values and principles such as public good, citizen centricity, equity, non-discrimination, accountability, and responsiveness of healthcare providers should be part and parcel of HRH policy. At what point of time are you going to communicate to the HRH in general that these are important elements of their day-to-day function? The second component that I would like to think about, or I would like to consider including, would be workplace values such as professional ethics and standards, safety, equality, which is non-discrimination, teamwork, and work-life balance. The third element that I would strongly advocate for inclusion in the HRH policy relates to recognition of all categories of healthcare providers under their interdependence. Unfortunately, we have created silos in terms of even among the healthcare professionals. So it's not about just doctors and specialists, but a recognition that there is a great deal of interdependencies and a mutual respect for each other's professional contribution. We should also be able to recognize the demographic transition within the health workforce itself. There is a gender parity and a gender equality that is crying need. Diversity of people coming from different backgrounds working as teams. The millennial workforce, a very large proportion of youngsters working, millennials we call them as, working along with the senior most people, and how to manage each of their aspirations. These are all challenging ones, but it must be reflected in an HRH policy. The fourth dimension that I would be looking at is recognition of the influence of rapidly changing healthcare technologies and innovations in healthcare delivery and healthcare dynamics or healthcare market dynamics, and its constant effect on HRH, such as job redesign. Gone are the days when 10 years back you could do the tasks as you were doing. Today, with the technology and the innovations in the service delivery mode, the jobs are getting redesigned, and the hours you spend, which is conventional wisdom of HR planning, needs to be thought through very differently today. And therefore, competency framework also changes. The learning and training methodologies changes. The compensation packages are changing. Patient relations are getting more complex. Regulatory regimes are coming into play. All of these must get reflection in the HRH policy. And the last one, I think people have already spoken about it, task shifting and inter-cadre transition. HRH policy should be focusing on, or at least reflect upon, the ability of what we are talking about to transition from nursing to perhaps into a full-fledged medical education after a few years, as you see in some other countries, as you see in Canada, as you see in some other countries. So if that could be also a part and parcel of our thought process, if ASHAs could be converted into GNMs at some point of time, maybe this can also be thought through in terms of other cadre transitions. And therefore, HRH policy should be flexible to address both external and internal changes within the health system. But finally, last slide, please. The success of an HRH policy depends on, one, a complete information or data and mapping of HRH in the country. So I would consider HR assessment mapping as a first step into implementing the HRH policy. The second is about legal and institutional framework, which includes your regulatory systems, norms, standards, guidelines, etc. Third, establish central and state level organizational structures. We do not know whether you will call them as HRH cells or departments or units, but that's left to the way that one can think about nomenclatures. And the implementing agencies provide technical advisory groups to guide and monitor both at the central level and the state level. Build technical and managerial capacity for implementing, for the implementing agencies. Commit funds and resources sufficiently so that they are not starved of any implementing bottlenecks. And fifth one, prepare guidelines and implementation plans, including monitoring indicators in terms of efficacy or efficiency of implementing the HRH policy. And finally, develop learning networks and cross-learning opportunities, both within the health system as well as across the health systems. But finally, the most critical part is political and stakeholder commitment for change, and therefore perhaps think about considering dialogue forums and facilitate negotiation with the relevant stakeholders. It's possible that the center can develop some guidance framework on HRH policies and strategies, and also provide some broader guidance for implementation framework, but the states must have an autonomy to contextualize and implement. This is not the task for the National Medical Commission. This has to be thought through at a different level. Thank you so much once again for giving me this opportunity.
Thank you very much, sir, for highlighting the need of HRH policy and its need in health system and delivery of services. Thank you, sir, for taking the time and efforts you took for sharing your thoughts. So now there is a slight change on request of Dr. Parkasma, and we will go to our theme 5 first, followed by other themes. So our theme 5 is nursing and midwifery leadership to be strengthened. And no one better than Dr. Parkasma can talk on this theme. She is the founder and president of SOMI, a public health researcher and advocate for 40 years with a special focus on studies related to maternal deaths. She founded Academy for Nursing Studies and Women's Empowerment Research Studies in 1994. She established the Friendship Foundation, a trust for working on harmony between the natural and human worlds, and frequently conducts short workshops on scientific writing, critical thinking, and conceptualizing research studies. Dr. Parkasma, over to you, ma'am.
Thank you. Thank you very much. Am I clear? Am I visible and audible?
Ma'am, you're audible.
Audible, but not visible.
Not visible, ma'am.
I'm not visible. Hopefully, I will be visible later because my video is on. But let's start. Yeah, because sorry, I took out of turn presentation. That's because it's been raining and raining, and there's no electricity, and my car is going out. So I wanted to speak. Okay, let's come to the point. I'm really happy that we have this conversation. 1.5 years. I remember the meeting we had in March 2020. I think it was the last meeting before the COVID locked us down. It was on 3rd, 4th of March in Delhi in NIHW. Speaking about nursing and midwifery leadership strengthening, that there is one of the 7 points dedicated to this itself shows how important it is. Because when I had a 2-day symposium with global participants, And this came out repeatedly again and again, that you can have good quality universal health coverage only if your health and human resource is good. And among that, only if your nursing, midwifery manpower, human resource is effective and taken care of. Now, before starting, I want to just make one statement. I will use the word nursing throughout my presentation because I feel when you combine two professions together, you're not doing justice to either one of them. When you combine nursing and midwifery, it's as though both of them are interchangeable and neither of them really gets justice. It's very obvious that the dominant profession gets the allocations, the status, the posts, and the not so dominant profession doesn't get the same status. If we take doctors and nurses, everywhere we say doctors and nurses and others, but who gets the recognition and the allocation and the status and the prestige? It's the doctors, and nurses come second. So I'm little wary of combining nursing and midwifery, especially in India where we don't have a separate cadre of midwives still. So I'll use the word nurses and nursing throughout my presentation. Just to make clear, till now I've heard the talk given by Dr. Srinath and also Dr. Venkataraman, and I feel that my presentation is going to be more actual action related, because once you've had a symposium and you have 7 action points, now we have to be directly going down to what is the action required? What is it that the governments and the managements have to do to make this possible? I'm going to use a word, image, IMAGE, to help me to carry you through this next 10 minutes. And hopefully I'll have 10 minutes to talk with you before my battery runs out. Image means that unless nurses have this image building, image boosting, all the programs that we do, trainings, research, collaborative work, there's 1 lakh nurses I heard are going to be trained in the next few weeks. All this is not going to help in strengthening leadership unless there is something very clear, the basic fact that nursing is going through a crisis. The crisis has been deepening over the last 20 to 30 years as more and more nurses have found out that they are not aware of what nursing is. The entry nurses think that they'll go abroad and do nursing there. And here in our hospitals and the clinics and wards, they will not do any hand-holding or hands-on nursing. They will only do some theory learning, and they will go abroad wherever they are going to work, and there they will do nursing. So this is one idea of nursing that we have in the millenniums that Dr. Venkataraman was mentioning about. The second is those who go for higher education in nursing, go for it with the hope of escaping from the duties and the clinical situation. Those who go for even further education like PhD, go for further delinking with nursing. They become professors and take up other major jobs. The government and policies have further made this more chaotic by taking away the identity of the nurse from nursing itself. For example, the ANM, when she became and was labeled the MPHW, the identity of being a nurse or a midwife was lost and she became a multi-purpose health worker. Same thing, the recent policy of having mid-level health providers has again further taken away the identity of very skilled nurse to become a mid-level. That means she's not a nurse, but she's mid-level. That means there's someone above her, there's a top level and there's a low level, and she's a mid-level. So this identity crisis that's deepening and deepening in nursing has to be first taken care of. And how are we going to do this? I think it's very difficult, very, very difficult. And it could start with education. Education which instills very deeply the identity as a nurse, as first and foremost a care provider, and then of course all other things. And this has to go with lots of self-esteem building, which is lacking today in nursing education, I think. The government, when it brings in other ideas like SBA, it further delinks and notifies kind of, what a nurse is or a midwife is. So for professional identity to be gained, strengthened and instilled in the newcomers, I feel we need clinical role models, clinical nurses who are highly qualified, who are actually working within the clinical area, and not only as administrators like head nurses, ward supervisors, and matrons and superintendents, but as clinical nurses. This is a crisis in India. We have not been able to develop a clinical nursing situation where role models, very learned, very skilled nurses who are equal to any other nurses anywhere else are working in our wards. The public image of nursing has to be improved. Today's public sees the nurse as someone who obeys the doctor or does whatever the doctor wants. The public image comes only through pictures, through direct interaction in hospitals when they go for care, or comes from movies and serials and things. So I think it's very, very important that we have something to boost the image and create an identity for nurses in India. And we can do this. And I'm thinking the government has to be, if it's serious about these 7 action points, and my 5th point, I think we need to encourage a lot of learning, a lot of Indian nursing books written by Indian nurses, perhaps commissioned, paid for, invited, a lot of research promotion by nurses for nursing care and how nursing care is given. Right now, I know so many of the MSc nursing theses are not really nursing care. They are more teaching type of thesis. PhD theses are similar. Unless research is done by nurses on nursing care to improve nursing care, the identity, the knowledge building, the nursing body will not develop. ICMR needs to have a research wing exclusively for nursing care. After all, more than 50% of the time patients spend with nurses, not with any other healthcare providers. Therefore, I think it's imperative that we look into this, writing of nursing research books, doing of research. I know countries which publish and invite proposals from nurses, only from nurses, for nursing care research. This could be done. So clinical role model, a learning role model, a research models, these have to be taken up so that this identity crisis is lost. Further, the public does not see nurses really practicing independently. So the public doesn't really know who nurses are, except what they see on the pictures and what they see as not very polite people who are very busy in hospitals when they go for care. Therefore, we need to promote clinics run by nurses, health education centers run by nurses, group education centers like diabetic care and all run by nurses. Nursing homes, the word nursing home means nursing care, but mostly that word nursing home should be applied only when a nurse is heading that or when nurses are running that. We need to have many more nurses practicing independently so that their identity as nurses is seen and that they become leaders. How can you become a leader when you don't even know who you are and what you do? I think that's very important initially. And the government needs to take this very seriously, that the nursing profession themselves have to have this identity. The program managers, all the hospital RMOs, the other co-professionals like doctors and pharmacists should also realize that this profession means this. Public needs to be informed. TV ads, I don't see any. Asha program started, so many TV ads. Asha Didi will come and she do that. Why are they it is also necessary to have given the commission, the latest commission is not.
Ma'am, I think we have lost the connection with ma'am.
It seems we have lost Elbin with
Yes, ma'am.
Dr.
Yes, ma'am.
Plasma,
Yes,
because
ma'am.
she had called me and she had said that she's having the battery problems.
Okay.
So I think meanwhile, what we can do is I will request Dr. Ruchi to please invite Professor MC Mishra. Go for another meeting. Ma'am, are you back? Ma'am, there is ma'am, there is a sound problem, ma'am.
Is this okay now? But I'm okay. I have battery life.
Ma'am, your sound is breaking, ma'am.
Okay, I can talk at least.
No, it's breaking. Ma'am, your sound is breaking, ma'am, and we have lost contact, unfortunately, with Dr. Prakasma. I think, ma'am, can we, meanwhile, if you are getting it corrected, we can go on with the next presentation.
But Rajni, I'm
ma'am, it is not clear.
Hello?
Yes, ma'am, you are not audible, ma'am.
Okay, then I'm sorry about that. Yeah, I'm sorry about that. Please continue with the other presenter.
Okay, okay, ma'am. All right, ma'am. Thank you. Over to you, Dr. Vandana.
Thank you, ma'am. Thank you so much. Thank you, Dr. Prakasama, for the action-oriented talk. It is true that we can only have health coverage if we have health workforce. So, ma'am rightly pointed out the identity of a skilled nurse has lost and it is deepening day by day. So, we need to encourage a lot of learning and research promotion for nursing care. Thank you, ma'am, for this enthusiastic and mind-boggling words. Now we have come to the theme 4, which is reform and education system to increase employability. And we have an eminent speaker, Professor MC Mishra, to talk on reform and education system to increase employability. Professor MC Mishra is a Vice Chancellor at Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, and a former director of AIIMS, Delhi. He was awarded Commonwealth Medical Fellowship in 1988 to undergo training in trauma care services at the Hope Hospital, University of Manchester. After which he contributed towards the creation and development of AIIMS Trauma Center, which is one of the main points of contact to provide state-of-art compassionate patient care to all acutely injured patients and those requiring its specialized services. Over to you, sir, Professor MC Mishra.
Yes, sir. Yes, sir, Professor Mishra.
Yes, I am now transitioning into my home from the car.
Okay, sir.
So let me just enter the home.
Okay, sir. We have your presentation is now uploaded.
Okay. Yeah. Okay. So, Dr. Rajni, can you hear us?
Yes, sir. Yes, sir.
Hear me?
Yes, sir.
Okay. So, thank you so much for the invitation and wonderful panel which we heard over last more than 1 hour about the challenges in health resources, human resources in health. At the outset, what I would say that there are numbers which are available and not utilized in India. We have almost more than 10,000 medical professionals who have completed their training. Somewhere in some country they return and they don't get opportunity. Then the NEET exam which we carry on for the entrance in MBBS or PG, MBBS is okay, but in PG what happens that majority of the students don't get their first choice of subject or the field in which they want to specialize. So that is another problem up front. I'll give you a scenario. I was on a TV debate on Doctor's Day, and some mother listened to that debate, and her son has done MBBS in 2010, and now it is 2021, and he wanted to pursue surgical career and he has not got it as yet. And there are a whole lot of people like that who are there in our society and they are not utilized. And as you heard, the nursing component, that we are preparing nurses to go in Gulf or overseas and not serve in the country. So we have human resource available on the one hand and not being utilized. That's one spectrum, and the other spectrum, naturally, we have a deficiency of healthcare we all the time talk about. And that is something which we need to address, that how we can address. There is a move. In 2004, we had, and if you talk of medical education and tertiary care, in the healthcare, there were 6 aims were announced, and they came into being in 2011, and they are still with 50% at least deficiency in 40 to 50% deficiency in their faculty positions. So that is another spectrum. And then now, in all fairness, the central government has taken a considered view to establish in each state one aims, so which is towards capacity building. Can I have the next slide? So when we talk about health, naturally it comes as a holistic health we talk about, where physical health is one part, which naturally the medical professionals do take care. The mental health also is very, very important, and we have seen that in COVID pandemic for everyone, that how the mental health of those providing healthcare and also those receiving healthcare was affected. And then the whole lot of societal component of this pandemic we have seen, and otherwise also anybody coming from a lower middle class or poor background and diagnosed with a cancer or diagnosed with a chronic kidney disease or any other disease, chronic illness, one can imagine what happens to that family. It's a whole lot of, and because of trauma, actually, it is one of the most common reasons for indebtedness in both urban and rural India. Then we also talk about spiritual health, where yoga and meditation do make a big component to maintain our health. Next slide. Now, we have not yet got over the infectious diseases. We all know, and we are seeing new diseases, new viruses like this COVID, and all these Zika, chikungunya, dengue, Nipah, malaria, tuberculosis. We have not got over malaria and tuberculosis. HIV, of course, has gone down, but it's still not yet over. Next slide. And if you look at the India is termed as the diabetic capital of the world. And this diabetes also leads to chronic diseases like cardiovascular diseases. That is the most common reason for disability adjusted life year lost. and also mental health illnesses, which are second to cardiovascular diseases in our country, according to WHO, where it leads to the disability adjusted fear lost. And then third position now, the injury for a disability adjusted life year lost. And this is what I say, then if I have a cancer, I might not get treated, but if I injure my bone or injure my body, I have to get it treated. So that is the reason that most people land up into debt while getting treatment for injuries. Next slide. Now, when we talk about healthcare infrastructure, naturally, the human resource becomes one component, but machinery equipment is another, and also the expenditure on creating this infrastructure. That's the third component of any healthcare environment. Next slide. And then India per se has a huge and a big rural component of healthcare. The people who live in 70% of our population lives in rural areas. There are advantages of living in rural area, but there are certain distinct disadvantages where access to health care is not as much as it is in urban area or semi-urban areas. And then we have three components: this primary, secondary, and tertiary. Naturally, the tertiary care is all concentrated into the metropolitan cities or tier 2 cities or tier 3 cities. So is the secondary level healthcare. The primary healthcare becomes very, very important, and that has not been addressed so far in the country over the last 50 years, what I have seen during my professional career. Next slide. So the objective of any, when we talk about human resource development in healthcare, it is basically to provide accessibility to the needy, those who need to access the health professional, and also it should be affordable. And that is the challenge in India, country like India, we are facing today. Next slide. So if we look at what infrastructure we have in India, rural healthcare, we have sub-health centers, sub-centers, what we call, which is for every 5,000 population, we have a sub-center. And this becomes 3,000 in hilly or difficult terrain or tribal areas. We have primary health center for 20 to 30,000 population, then community health center for 80,000 to 120,000 population. And now, as mentioned by Major General, that wellness centers are being established. So that is something, I don't know whether it is in addition to these community health centers or there will be upgradation of these community health centers. We'll see that in coming times. Next. Next slide. So if we look at how many PHCs we had, so we have close to 30,000 PHCs in the country, and majority of them are located in rural areas, and there are over 5,000 located in urban areas, and this is supposed to provide the primary care or referral to those who need when they approach these centers. Next slide. So because there is the deficiency of human resource to man these primary healthcare centers, that this healthcare infrastructure becomes weak. And that is something we need to understand. Because our hospitals, secondary and tertiary care hospitals are concentrated in the towns, cities, metropolitan cities, and the primary healthcare in both urban and rural areas become weak. We have seen that in Delhi, during the pandemic, we thought that the so-called much hyped mohalla clinics will be very handy to deal with the pandemic, because 85 to 90% people don't need hospitalization, they can be treated and they can get well at home. But that didn't happen. These mohalla clinics served no purpose in Delhi, which were established with much fanfare, but then they didn't come handy during. So there is naturally a massive shortage. What they did to man these mohalla clinics in Delhi, what we learned, that they posted doctors drawn out from these tertiary care hospitals or secondary care hospitals and posted them in mohalla clinics. Now you cannot deprive one healthcare component and then try to augment the other one. And that is something cannot be done. And that is why we are discussing this, how this healthcare resource of trained manpower can be bridged and can be supplemented. And naturally, there is a huge deficiency of both paramedical staff and all nurses, as well as the laboratory trained technicians. Next slide. Now, if you look at the public healthcare facilities in India, these primary health centers, these many, community health centers, because these many, over 5,500, sub-district hospitals, over 1,000, district hospital about 1,000. So total, these healthcare facilities put together are 37,700, more than 700, and they are having put together over 700,000 hospital indoor beds. Now, how many of these PHCs are in rural area? And then the beds, these basically the sub-district and district hospital. So in rural areas, close to 20,000, and these many beds, close to 279,000 beds, and sub-district hospital in urban areas. You see these hospitals, majority of them are in urban areas with these many beds, over 400,000 beds. Now, in addition to these allopathic system, what is established, there is a Ayush facilities also. And this Ayush facility, basically, if you look at, they are almost close to 4,000 with almost more than 50,000 beds. So this resource is already available to us, both the human resource as well as the infrastructure. Defense, we have 133 hospitals with over 34,500 beds. Railways, again, 126 hospitals with more than or close to 14,000 beds. Then the ESI hospitals, or 151 hospitals with close to 20,000 indoor beds. Next slide. Now, if you look at private healthcare providers, in India, there are close to 44,000 private healthcare providers with almost 1 million beds, 60,000 ICU beds, and almost 30,000 ventilators. And this on public side, we had as 739,000 hospital beds, the ICU beds around 36,000, and ventilators less than the private sector. Next slide. Now, so if you look at the human resource challenges, there are 5 big challenges in human resource issues in healthcare. Recruitment is one, and that's the reason I said a lot of nurses, they go overseas, a lot of doctors go overseas, they are not, they don't get placement, proper placement. And this same problem, like other industries, also is hampering healthcare as well. Then wage competition. If you look at the nursing wages across states in India, they vary hugely. We were interviewing almost 1,400 nurses for AIMS some time ago, and you would be surprised the salaries quoted, what they were getting in Kerala and then what they get in Delhi. And that's why these nurses, they migrate from Kerala to other parts of the country or overseas, because salaries are so meager in Kerala that they have to go out. And then turnover and retention becomes a challenge in healthcare. And burnout all of you have heard, and it was talked about also, the burnout during the pandemic, even before the pandemic. Because of this deficiency, the burnout also takes place. Then training and development. There was no system where we could have basically trained these either nurses, doctors, or other healthcare workers into communication skills, into how to talk to the patients, and then also the safety, patient safety, hospital safety. Now, of course, there are initiatives in corporate sector which are being taken towards hospital safety. Also, we have taken at AIIMS, and other institutions are also taking. And then naturally, the digitization. I think it will do a lot of good to healthcare by putting in artificial intelligence and digitization. And naturally, the privacy of the patient is extremely important in healthcare. Next slide. If you look at National Health Workforce Account 2018, it reported around 5.7 million health workers. The 1.1 million were allopathic doctors, 2.3 million midwives or nurses, we don't call them midwives, pharmacists 1.2 million, dentists 0.27 million, and naturally the traditional medical practitioners, majority of them are Ayurvedic practitioners, 50% of them, 0.79 million. But then this data was not agreed by another agency, NSSO, and they said the number is much lower. If we take doctor and nurses per 10,000, then it is 8.817, and it is much below what we need to have. This should be, and then we have 6.1 or 10.6 for both the doctors and nurses. Next slide. So the number further drops to 5 and 6 doctors and nurses respectively after accounting for adequate qualification. I think that has to be addressed, that they are not all well qualified, and that is a problem. And so if we look at these estimates are much below what the standard set by the WHO. The results reflected highly skewed distribution of health workforce across states. Southern states are better than northern states. Rural and urban divide, public and private sector, and substantial portion of active healthcare workforce not adequately qualified. And that's we were interviewing a professor of medicine very recently for an institution, and basic questions about COVID, he was not able to answer. So that is a huge worry, that how do we inculcate this culture that they don't attend CMEs, they don't listen to the webinars. There is no, even today, our CME credits are not mandatory for medical professionals. They are not mandatory by any medical council, or let's hope that National Medical Commission does some work in this direction. And 20% of qualified health professionals are not active, and they are not available. So one has to remember, and even in COVID, it happened. People are not coming for work. Naturally, obviously, senior citizens, those who have become senior citizens, they are not coming for work for obvious risk of contracting the COVID and risk of dying. Next slide. Now, when we look at medical education, now there are 540 odd medical colleges, and there are 64 standalone institutions of national importance, PG institutes in India. And then if we look at, and they in total make up for 118,000 MBBS seats approximately. This has been increased recently. And then if you look at 118,000 MBBS, then we look at postgraduate. I think if I read somewhere that it's not 44,000, it is 48,000, but it's still less than half of MBBS seats. And that is where the problem is coming up in medical education, that everybody who wants to do specialization is not getting it. And also they are not getting their choice. And that is what causes a lot of problem. Also, if we look at the post-graduation, we need more family practitioner, general practitioners, general physicians in rural area, in semi-urban area, in urban areas. In COVID pandemic, there was huge need for such a cadre, but we didn't have one. And that is something we need to think how we can create that cadre, which will work very effectively to deal with universal health coverage we are talking about. And then naturally we have super specialties, these many, almost 2,500. But the problem is, if you look at 540 odd medical colleges, about close to 275 of them would be in private sector, rest of it in public sector. And if we look at the PG seats going vacant in preclinical subjects, basic science subjects, anatomy, physiology, biochemistry, pathology, pharmacology, and in these subjects, even community medicine, there are no takers in the private colleges. Forensic medicine, for example. So there is huge cause of concern because of this. There is a huge shortage for manning. Now, government has planned to have one medical college in each district. Now, where are they going to get the faculty? When AIMS institutions are not attracting faculty, how are they going to recruit faculty for these medical colleges in rural areas? And that becomes a challenge. Even if you have established an institution, it's a challenge to attract and retain that those faculty members. Of course, the new AIMS, as I mentioned, every state is going to have one. Some states have more than one. And there are upgradation of these institutions under Pradhan Mantri Swasthya Suraksha Yojana, which started with Dr. Manmohan Singh when he became Prime Minister. After Mr. Vajpayee's government announced 6 AIMS institutions. Next slide. But in last 7 years, I must say, the Modi government has given some impetus to healthcare by announcing one AIMS in practically in every state. So if you look at nurses, of course, there was already a talk about nurses, but the same problem remains with nurses also. At trauma center, when I was there, we tried to empower our nurses. They did fantastic research. I also allowed them to take foreign travel grant, but it is not uniformly available to nurses everywhere. So there is a huge lot of funding which is needed if we want to create even some sort of a reasonable human resource in health. It won't happen without funds being made available. I think that is where the core problem lies. Nowadays, whatever funds have been allocated, higher funds in the healthcare, they are for the COVID, to deal with the COVID, the vaccine, etc. Next slide. So the solutions, basically, what I always say, when we talk of deficiency of healthcare, human resource in healthcare, we do not count the Ayush doctors in India. We must now count them, add to the allopathic doctors. So our deficiency will not that much, because they are serving the country. A lot of people go for consultation. We ourselves go for consultation for non-surgical issues and the problems which have not been taken care by the allopathic system. That has happened. So this cadre is available to us. We must count them for our healthcare human resource. And of course, if we look at 2020, 1.2 million doctors registered with allopathic system, and also we have human resource in health available. We need to use it to its fullest potential. I can tell you what I was mentioning, that most private medical college hospitals have staff, they have faculty, they have residents, they have nurses, there is a hospital, there are beds, whole lot of infrastructure underutilized, grossly underutilized, I can tell you with my personal experience. So it is not that infrastructure is not available in the country. Let's use whatever is available and then see what we need further. I think that has to be seen, not just blanketly say that we are deficient and we need, because why these people want to go to Gulf or to overseas? They are not getting jobs here. Naturally, they'll go. So I think we have to look at from that perspective also. So utilize first available healthcare infrastructure optimally, both in public and private, and use our allopathic and Ayush doctors together. They must make a pool to our healthcare human resource. Next slide. We need to invest in human resource in health. It cannot happen without investing into it. That is absolutely important. Improve the skill mix, which requires investment in professional colleges and technical education. This is happening, but more needs to be done. We also need encouraging qualified health professionals to join the labor market openly. Even if they can do something, they must not sit at home as long as they can work. And then we need to incentivize our young workforce to go to the rural areas by rotation or whatever mechanism we can evolve, so that because they have family, we have to see how best we can use them and rotate them from the rural areas, give them some difficult area allowance, as happens in many countries it happens, and we must do that also. Leverage telehealth and telemedicine, which has now been established during pandemic very well, the video consultations. I think that is something we all must try and do. That will improve our accessibility and affordability both. Next. So thank you, Rajni-ji, thank you so much.
Thank you, sir, for highlighting the spectrum of HR problems. And on one side, our human resources is not being utilized properly, and on the other side, we do not have adequate HR. Thank you, sir, for sharing your valuable thoughts.
Thank you.
So now we go to our next theme, that is, ma'am. Yes.
Your leave, because I have to join.
Dr. Mona.
So, ma'am, kuch bol. Sir is saying thank you.
One second. Sir, thank you so much. Sir, this was a very meaningful presentation and very thought-provoking indeed.
Thank you so much. Take care. And
we have, sir, it is not, one second. Sorry, sir, my speaker was off. Sir, thank you very much. It was indeed a very, very thought-provoking presentation, sir.
Thank you, and take care and have great health, and we'll keep in touch.
Yes, thank you so much, sir. Thank you. And now we will, Dr. Ruchi, we will go over to Dr. Mona.
Yes, ma'am. So next theme is HRH units at central and state directorates for promoting universal health coverage. And it will be addressed by Dr. Mona. She has more than 22 years of experience in health sector. She is member secretary of working group to develop roadmap for human resources in health, and member of committee constituted for the revision of Indian public health standards. She is looking after the planning and results-based fund disbursement under the National Health Mission. Dr. Mona, over to you, ma'am.
Thank you, Dr. Ruchi. At the outset, I must congratulate NIHFW team for holding this HRH conference in January, something that we have been waiting for last 15 years, I would say. I don't remember when it happened last. So I think the congratulations should go to Professor Rajni Bagga and her team for getting it done. So the topic today that I have been given is HRH units for promoting universal health care. I think it is a well-recognized fact that we need adequate number of human resources, and there I don't need to stress. All the speakers before me, they have already touched upon all those points. So I'm going to try and stick to my topic and be within time, because I know that there are two more speakers perhaps to go after me. Next, please. Next, thank you. So if you see the current situation, one of the speakers rightly pointed out that on the private sector side, we hardly do anything. It is only through the acts and legislation that we are trying to do something, and that also Clinical Establishment Act and the new NMC Act that has come. So my topic, I'm trying to restrict myself to the government sector. But here also, health is a state subject, as you all know, and medical education is the one which comes on the concurrent list. So within this ambit, let us try and find out what we can do about these units at the central level and at the state level. Next, please. So at the center and the state, we have been saying about this integrated team for quite some time. This is not a new concept. But of late, we have been trying to work this out. And what seemed a very doable thing theoretically, in practice, we found it very difficult. India is too big a country, too diverse, too complex, and there are so many organizations and directorates. And it is easy to do a organization chart and change one's reporting from one directorate to another, but in practice we all know how difficult it is. So I think what we need to emphasize on is not an integrated team, but a coordinating and a collaborating system, a body which can meet at a given periodicity, and the processes that are required to bring all these central bodies together and move in the same direction so that we can, achieve our goals and the outcomes. This thing is true for the states as well. So if you look at the states, there are many states where we have the health and family welfare as a separate department and medical education as another department with a different secretary. There also, this kind of team at the state level is very difficult. But we do understand that we need some kind of mechanism where we can collaborate with the other directorates, other departments, and bring everything together and see to it the way we are doing in COVID, that many of the departments, wherever there is, wherever they are dealing with health and human resources, we have come together and trying to work out. Next, please. Another question that came to my mind was that should we only talk about the central and the state level team, or should we also think about the regional and the district teams? Now, regional teams, I think it is of utmost priority now. In bigger states like UP, Madhya Pradesh, Bihar, Gujarat, we need to have regional level teams. And what about districts? Some of our districts are as big as a small country. And how can we leave the district people without HRH unit? Whereas in any private organizations, not only hospitals, you would always see that there is a human resource team, a small unit at least to look after. But in government, most of the time, we leave these things to the administrative assistants who most of the time are not trained on human resources. So this is something that I would like this August gathering to think about, that this regional and district team also we need to have. Next, please. The next question that comes to our mind is, what kind of team should we have? And I think it has to be a multidisciplinary team. We have to have all kinds of people, representation of all the cadres in our HRH team. We need to have doctors, allopathic as well as Ayush doctors, nurses should be represented well, pharmacists, physiotherapists, social scientists, public health specialists, and of course, human resource specialists and managers. Because most of the time I see that this is one specialty that we don't talk about. Knowing public health is good, but you will see that in India, the management part of the human resources and the development part is still neglected. And I'm glad that today Professor Venkatraman also brought this up. Next, please. This is my last slide, and here I would like to talk about the roles and responsibilities that the state level and the central level bodies should have. And if we have regional and district level, they should also have these roles and responsibilities. Of course, human resource policies and strategies are of prime importance. If we come to the central level, human resource policies are difficult to make for such a big country. But we can always have guidelines and guidance note for the states so that they can have their own human resource policies and strategies which are contextualized as per the state's requirement. I think sometimes even within the state, the districts also are vastly different. There also we will have to change the strategies, but we must give the district, the region, the states, the strategic options that are available, because there could be a technical challenge of capacities at that level. The HRH planning is something that we do in India, be it in parts, but we are trying to do the planning, at least in NHM, there is a lot of planning that happens in human resources. But when we come to the high quality HR data, this again is a problem in India. As you know, most of the time we rely on the council data, which is not a live registry. So having a live registry is again another priority, and that this team at the central and the state level should look into. The projection and planning for current as well as future demand and supply. This should be another of the responsibilities. And not only this, but the distribution, the geographical distribution, the equitable distribution that the speakers talked about, the skill mix, where we don't only talk about the specialists and the doctors, but also the nurses, the physiotherapists, and all other cadres who make a team. That is more important. Also about the acceptability and the productivity of human resources. Acceptability, when it in recent days, we were having a discussion on the COVID human resources, and language came up in a big way. Sometimes when both the parties are wearing PPE and talking in some other language, even if they are talking in English or Hindi, it becomes very difficult for the other person to understand. So things which matter to the patient, that we need to keep in mind. And lastly, costed plans. Many a times when the committees give reports, there is no costed plan. So how much budget would be required? And this again brings back to the 2.5% of the GDP that we badly need for health. Another part is human resource management and human resource welfare. When it comes to management, I think broadly we have restricted ourselves to recruitment and selection and a little bit of training. But beyond that, what about the induction training? What about the continuous capacity building and the choice of getting trained in a particular area? That choice is not available with the human resources. What about their career pathways and the performance appraisals? How do we increase and improve their productivity and also the retirement? When it comes to human resource welfare, I think this is something that has been neglected, except for the regular employees where we have some kind of post-retirement benefits. For the contractuals, we hardly have anything. So why aren't we thinking of crutches for our human resources? The spousal transfers are still not the normal thing. So you have to really, push hard to get the postings together. What about life insurance, health insurance, even health checkups? We are in the health department, but getting an annual checkup for all our healthcare workers is still not, something that is done regularly. And in fact, priority vaccination, particularly when it came to COVID, we managed to do it for human resources. But what about their families? Also the psychosocial support and the helplines that they need. How do we make better work environment? And not only in terms of team building and better facilities and office spaces, but also through good policies and processes where we go beyond what is normal. I will give you just one example. Sometimes when I go to the States and find that the nurse says that, every month 2 or 3,000 rupees or 4,000 rupees is deducted as TDS. Sometimes I ask the finance teams there, can't you help them to get their TDS back? Can't you help them in filing their tax returns? This is a very small gesture on our part to say to the healthcare workers that we do care. Also, greening of the facilities and our offices, make it more environment friendly. And also, I think the speakers before me spoke about the newer technologies, but I would like to use these newer technologies to lessen the burden of our human resources, and how can we make their work easier, faster, and better. Apart from all this, of course, capacity building and research and evaluations are going to be among the roles and responsibilities. I think when it comes to the teams, the HRH teams, we don't need only the knowledgeable and skilled teams, but we need empathetic teams. Another example that comes to my mind is from the central level, do we keep in mind small things which affect other states? For example, in Northeast, that at 4:30 p.m., it becomes 8:30 p.m. for them. But many a times we have meetings which run till late night. Can we just think of them and have their meetings in the morning? This is a very small thing. What I was trying to tell you is that knowledge and skills and technical specifications are all fine. But as human resource teams, we have to have this kind of empathetic listening of the entire country's requirements, and then only we'll be able to do well. Thank you so much.
Thank you, Dr. Mona. Thank you so much for focusing on the roles and responsibilities of all the responsible HRH units. In order to achieve UHC, it is important to think that who is going to look after the human resources for health and how. And so we would like to thank you once again, ma'am, for sharing your thoughts with us. Now our next important theme is on nursing and midwifery directorate at central and state level by Dr. Manju Chugani. She is HOD Ops and Gynec Nursing and Paramedical Sciences at Jamia Hamdard. She has more than 28 years of extensive hands-on experience in the area of maternal and child health and university teaching. She initiated Society of Midwives in India in year 2000 and initiated Hindi Delhi chapter in year 2019. She is the country contact of midwifery today, an executive member of White Ribbon Alliance for India, and serves as a board member of Midwives Alliance of Asia for advocacy of midwifery in India. Recipient of various awards and appreciation, including the prestigious Mary Gobrin Agent of Change Award for the year 2020. Certificate of Achievement as Most Influential Women among 51 Most Influential Women in India, Nari Shakti Ko Pranam 2020, and International Midwife Award at Prague 2014. Over to you, ma'am, Dr. Manju Chugani.
Thank you so much for inviting me for this presentation, and it has been a long day, and hearing all presenters, all stalwarts. In fact, it was a pleasure to attend. And I must tell you, Professor Rajni Bagga, that you are lying that you are getting retired. I don't believe that. And thank you so much for inviting. And I know that there is a paucity of time. I will skip some of the slides, which are very important. 3 slides are very important in this, which I can't skip. And it is, we have heard from all other dignitaries also that nursing, how important nursing and midwifery profession is. And there is need of leadership. That also we have already heard that there is a need of leadership. I'm not able to change the slide here. No, okay. So I'll skip these slides. Yes, we all know that nurses are heroes, and health workforce. In earlier presentations, also many have shown this, that there are a lot of healthcare providers or workforce, but nursing and midwifery is one of the very, very important and paramount importance, as it constitute the largest workforce in healthcare delivery system. ये next क्यों नहीं होता है? The National Commission on Macroeconomics and Health also acknowledged this, that strong support at the policy level is required to ensure the policy implementation, because if they are not involved or they are not supported in the policy decision making, it is not going to go further. And this selection recruitment, this has been already discussed, so I can skip this. Principal challenges which are faced by the nursing workforce is that decision making related to the nursing workforce rests with the medical directorate. So that is the biggest challenge. I think the solution of this is creation of the directorate, which is headed by the nursing personnel, and the people working there are also from the nursing background. Because I don't understand the problems of my neighbors, I will understand problems at my home better. That's the reason why it should be. Then minimal involvement, nursing professionals in policy framing and decision making. Now I would say that it has started, but it is very, very minimal. It should be at all levels, all initiatives. Leadership crisis of the nursing and midwifery workforce across India. This has been already highlighted a lot. And it is not because of lack of leadership, because of lack of policy decisions, the organizational setup which should be there at the ministry, at the central level, and at the state level. At the state level, we have like Department of Health and Family Welfare, which is headed by the minister. 1 or 2 principal secretaries are there. Commissioner of Health and Family Welfare, head of the technical wing. And then there comes the director, additional director for medical education and health services. So why don't we have parallelly, there is nursing directorate or additional director for nursing education and health services. So it should be parallel to that, so that from the beginning itself, they are involved in policy, and they are the ones who are deciding the policies and strategies for nursing profession. And in this also, you will find that there's no uniformity in the number of directorate level nursing administrative positions across all states. Some states have 1, some states have many, and many states are not having any. So that's the way it is running. And there is a lot of discrepancies which I have highlighted here, that some states have created the post and some states are under, like they are having these positions and they are under, but they are still under the supervision of Director Health Services. So it needs to be changed. I'm not going through the whole content, but the crux is this. Discrepancies in nursing positions at the directorate in the various states of India. There are senior level posts like Joint Director Nursing in UP, Assam, Manipur, Tamil Nadu, Kerala. And there are positions like as compared to the post of Deputy Director Nursing in West Bengal, Odisha, and Rajasthan and Gujarat. So there is discrepancy difference in the positions also. However, presence of certain posts does not reflect its involvement in the decision-making process. In one of the state, I will not name the state. In one of the state, I saw that there is a directorate And there is a nursing personnel joint director as nursing personnel, but she's not supposed to say anything in meetings. She's not supposed to take any decision. That decision will be taken by the doctor in that directorate. So what I mean to say that the position may be there, but it does not reflect the similar kind of involvement in decision making. That's also one of the challenge. Not only in Kerala and other places, there are other states also, and there are discrepancies in other systems. Like West Bengal, separate nursing division within the state health directorate is there. 15 positions are sanctioned, and in comparison to only 2 such positions in UP and 3 in Tamil Nadu. Tamil Nadu has a unique organizational setup where nursing issues are taken care by 3 directorates. And it is Director Medical Education, Directorate of Medical and Rural Health Services, and Directorate of Public Health and Preventive Medicine. But all the nursing issues are taken up by them. And then in Kerala, there are 3 nursing posts under Director Health Services and 1 under Director Medical Education. And in Bihar, there is no nursing position at state level at all. So yeah, there are discrepancies in these like deputy director or additional director, but the pay packages are also different in state to state. It should be same actually. If there is a deputy director nursing in one state, it should be similar pay scale should be there in other state also. Then paradigm or uplifting of the profession. In West Bengal, we have seen that because of this JD and DD nursing over the last many years, along with an active profile, they have attempted many initiatives, more nursing development issues in comparison to the other states. That means it is very, very well established fact that if we have a separate directorate, the development or the trajectory is different of the development in relation to the nursing. And the post of DD nursing came into existence in 1975 there, and the state was the first to start the nurse practitioner in midwifery post. Along with the strengthening its nursing teaching, the nursing division is headed by DD nursing, and more reforms are required to upgrade this post to director nursing. So this is the state of affairs in West Bengal. And I think if we start with this also, there will be changes in other states also. And the leadership and decision-making powers also, I have highlighted here that they need to have the powers along with the position. Not only like in one state I gave example, it is not that they have the position but the powers are not there, then also it is not useful. So this is very important. Along with the position, empowerment is required. Next slide. Next, yeah. So management process is job profile and role and salary. These should be very clearly written, because it is not clear that what is the, I mean to say SOPs are not there, what the DD or JD nursing person is supposed to do, how much is their empowerment, autonomy, or what decisions they can take. And there's no uniformity in the pay scale also, as I said. And in most of the states, the teaching cadre is relatively better paid than the non-teaching cadre. So that is also something very important which we need to pay attention to when we are planning these HRH policies. And placement policy, there is partial implementation of the policy guidelines for transfers, and in various states like UP and MP, the decision making for transfer to other is influenced. And in the other states like West Bengal, Kerala, TN posting and transfer guidelines are available and are followed very well. Do not have any administrative or financial powers. They do not have any administrative or financial power, but the guidelines are there. Deprived of decent infrastructure resources, and in most of the office and official resources are minimal. Like if you go to the office of medical directorate, you will find it is fully furnished, but it is not so in case of nursing. Next slide. This speaks about the selection criteria, career planning, and promotional avenues, which I think, in short, I would say that there is no uniform promotional guidelines. Few states are having specific guidelines and others are not having. Salary structures are different and promotions are based on seniority at all levels. Absence of merit and qualifications as the criteria for promotional growth has led to demotivation among the nursing professionals. In various states, the seniority list for the senior level positions are not being kept updated. So that also is demotivating. So uncovering gaps or key conclusions, the nursing management structure is majorly managed by senior policy makers and from the medical fraternity, and provide very little scope of nursing professionals to participate in policy decision making and to bring about any reforms. Across the country, there is very weak organizational structure of the policy making bodies at the directorate level in terms of nursing positions. West Bengal is the only state that has a separate nursing director division headed by the DD nursing. It is there in Odisha also, but is not fully or independently managed by nursing personnel. In the absence of any nursing position at the top decision-making level in the directorates, all policy decisions are framed by medical professionals and administrators, with nursing professionals having only a marginal say. Lack of decentralization, autonomy, and financial powers with the nursing administrators has led to the unnecessary delay in administrative and other managerial affairs to the nursing workforce. And there is no uniformity on HR issues concerning to career graphs, and nursing leadership positions at the state directorate has also led to the weak supervisory structure for the nursing staff, both in clinical and public health. The need of the hour is to bring about institutional reforms by creation of nursing directorate in each center as well as each state, and I think it was highlighted in reforms, educational reforms also. Next slide. So these are the major recommendations, that there is a need for parallel or equivalent authority to nursing profession as it is with medical. Then setting up separate directorate, and directorate at the directorate should be headed by the senior nursing professional in the post of director nursing, and then more powers and autonomy to be given to them. Clear SOPs are needed to be drafted on each level, and the contribution of the nursing cadre to overall health of the nation demands more visibility. And I think that's the last slide. Yes. You get what you work for, not what you wish for. So we are trying to work hard for this, and Rajni ji has done a wonderful job by bringing us all together on one podium. Thank you so much for inviting me.
Thank you, Manju. We share a common passion.
Yeah.
Thank you so much. Over to you, Dr. Luigi.
Thank you, ma'am. Thank you so much. So now we have come for today's last theme, that is provision of safe and secure work environment for HR. And this will be taken by our own Dr. Professor Rajni Bagga, the HOD of Social Sciences in HFW. She holds doctorate in psychology and postgraduate degree in human resource management as well as in public relations. She has more than 30 years of experience in applied research in behavioral sciences and human resource management, and has been an eminent part of various research studies carried out in collaboration with various international donor agencies. She has conducted a large number of training courses in HR management, leadership development, counseling, and communication skill, and participatory learning and action. Her prime focus is on developing and strengthening leadership skills of nurses and midwives. Over to you, ma'am.
Thank you so much, Dr. Ruchi. I think I didn't need this kind of an introduction. I hope my slides are being shared.
Yes, ma'am.
Dear friends, you all must be wondering that why we are overshooting the time. You have seen that how much of appreciable presentations we have had from one of the most distinguished speakers in India. And they have all spoken with so much passion. And I think we are very fortunate and very blessed to have such kind of presentations to take this agenda forward. Now, during our report writing, this was the real deep concern and emotional concern for almost all the participants, that the healthcare providers need to have a very safe and secure environment. And when we talk about the safe and secure environment, this is not just the physical I'm talking, this is about the mental, emotional safety. Performance of healthcare system and its outcome depend ultimately on the knowledge, skill, attitude, motivation of healthcare providers who are responsible for delivering the health services. The healthcare service sector requires the healthcare providers to be having a safe, secure, and enabling environment which motivates them to provide quality of patient care. The healthcare providers' requirement for this safety, security, comfort, dignity, even their human rights has to be given topmost priority. And when we say health workforce, we are starting from the physicians to the nursing, to the dentistry, pharmaceutical, laboratory, management support. I would say the sanitation workers, even the security staff. I think they are all the providers. They are all contributing for the safe, secure services in the hospital. And now in my presentation, as per the concerns which were voiced during the two-day symposium, I am restricting to three major concerns. Number one, what are the strategies we need to have to prevent violence against the healthcare providers in the hospitals at service delivery? What are the strategies to mitigate burnout and work stress among health workforce? What is the provider satisfaction among the workforce to sustain their performance outcome and building positive work culture? These were the major concerns which were voiced by all the speakers and the participants all. And these are the driving issues that we found and we understood, which provide the safe, secure environment, starting from need for effective leadership to robust plan to optimize utilization of HR, job enrichment, multitasking, need for gender equity, preventing violence, mitigating burnout, and providing them the work culture. First of all, I will take the first concern, that is the violence against healthcare providers. You have seen in the recent 1.5 years since we are all fighting with this pandemic, and our healthcare providers are the real warriors who are holding us together, who are keeping us alive. And they are the ones who are facing the brunt of the major violence in the community. And it has been reported that 75% of doctors across India reported to have faced at least some form of violence. And nurses, in a study, it was found at AIMS that 16 cases were among nurses, Group C staff had 9 cases, and doctors had 8 cases. So these days, I have seen one of the most popular common debates on television is on safety, security of healthcare providers. Even our print media is full of these measures. The central government has given an ordinance that will make acts of violence cognizable and imprisonable. Like the cabinet in last year had approved the promulgation of the ordinance to amend the Epidemic Disease Act. Such acts of violence can be cognizable and non-bailable. A person can be sentenced to terms between 3 months to 5 years and fined 50,000 rupees. But my own concern is that is this punishment is the real deterrent? I think we need to build up certain intervention preventive strategies in the institution, which I will come in the later part of my presentation. And I think I should move quickly. Now, my second concern is we are seeing a lot of stress, burnout, mental health issue, suicide rate, so many psychosocial issues which our healthcare providers are fighting with at the workplace. Burnout, a psychological response develops in providers in response to excessive prolonged exposure to stress, exposure to too much of work pressure. And there are so many causes of burnout, personal environment, but my concern is work-related hospital situation. One of the main causes of burnout is work pressure, reduced human resources. We have seen that our One Health workforce is giving the work output equivalent to 4 and 5 people. So there is so much of work burden. My own studies, research work carried out on burnout and stress. I have identified these factors: role ambiguity, role conflict, lack of recognition, lack of appreciation, and lack of work dignity. And the consequences, I will talk at the institutional level. There are consequences are increased turnover. We really have to carry out some kind of an study that what is the rate of turnover of doctors, nurses, and other healthcare providers from the public to the private institutions. And one of the reason is lack of enabling environment. Then institutional image and credibility is impacted, loss of trained human resources, and we are compromising on quality of patient care. These are the major consequences of burnout. And my third concern here I am talking about is the provider satisfaction, provider motivation among the healthcare providers, and building the positive work culture. And high levels of absenteeism and staff turnover are issues of concern for everyone in the service sector, and more so in the health sector. Employee satisfaction and retention need urgent attention. And one of the main interventions today that we need to motivate and activate and increase the performance of health workforce is job enrichment. And job enrichment in terms of providing them skill variety, task identity, task significance, and giving them more autonomy. Today, in the beginning of our webinar, Professor Kotwal and subsequently even Professor Srinath Reddy talked about it, and Dr. Venkat. We need to focus a lot on multi-skilling and task shifting. Our human resource has immense potential, immense capability. We just need to manifest this potential. And with the limited human resources, we should start with multi-skilling them. And now at the end, with 3 concerns, that is violence, burnout, and provider satisfaction, I would like to talk and present in brief that what interventions we need to be initiated in our systems. Right from the policy level, we need interventions. We need interventions at the hospital administration level. We need interventions at the healthcare providers' own individual level also. First of all, I will talk about what interventions at the policy level. Everybody today has talked about increasing the human resources. We need to have HR policy at the state and the central level. Can this HR policy take care of HR mapping and time to time to look at the number of human resources gap that we have, and we have to fill it up? And I think we really need an HR policy in this, in the long run, will take care of these problems. We need to have legal cell for the healthcare providers. Of course, we need budget increased. We need this increase in budget to focus on the welfare measures for the healthcare providers, not on budget for the infrastructure improvement, but for people-specific budget we need. We need revisions in the medical education curriculum. Another thing which many people have given me a feedback during my research studies, that the common 24/7 helpline that we need a helpline. And now there are so many interventions which have to be taken care of by the institutional heads, by the directors, by the deans, by the hospital administrators of the medical colleges and hospitals. That is, what plan do we have for grant of study leave? One of the reasons of burnout that the nursing professionals told me during my research study was that we have no transparency in grant of study leave. This is all ad hoc. You show me the face and I'll give you the leave. So this really leaves the human resource very, very frustrated. We have to follow the guideline for working hours, security and safety, safety for women, the gender issues, the gender empowerment, then appropriate staffing, adequate restroom and facilities. I'm sure all of you will agree, if you take a round of the hospitals and you want to see the restrooms and the toilets of the doctors and nurses, I'm sure you will feel very sad about it. Now, these are very important issues which give them a sense of dignity and comfort. Then reward, recognition, student support, wellness measures are very, very important. Student and medical fraternity and nursing fraternities forum for redressal of their problems. Now, moving from policy to the hospital, now I come to the measures and interventions that we need at the healthcare provider's own personal individual level. What kind of mentorship roles that they built with the seniors? Training to build emotional intelligence. I'm so glad Professor Srinath Reddy, who is a very, very eminent cardiologist and public health president in India, he always talks about building emotional intelligence, not IQ alone, but emotional intelligence, building self-awareness, building empathy among our healthcare providers. There has to be recreation of problems and sharing of best practices. And friends, another thing that I found during my work was that the resilience, that the ability to bounce back, to have the sense of hardiness is very important. Now our MCI has brought about a competency-based curriculum wherein there is a focus on increasing empathy and interpersonal skills. So I think practice of yoga, deep breathing, relaxation exercises are extremely important in work situation. And this we saw during the COVID pandemic, that how many big hospitals like AIMS and Safdarjung and so on had inbuilt these yoga and relaxation exercises for their COVID pandemic healthcare providers. And so these are I think the three measures we have to initiate from the policy level to the institutional level and to the healthcare providers level. Another thing I want to stress over here while I end my PP is health professionals, associations, societies, organizations from all specialities should unite today in speaking out forcefully against all acts of discrimination, intimidation, and violence against healthcare providers. Thank you so much. I'm sorry we have overshot this time, and I am very sorry about it, but we could not help it. Friends, we would have loved to have discussion and taken a few questions, but the time has not permitted us. I hope all of you have enjoyed listening to these all 7 presentations, and also starting with our chief guest and guest of honor. And we have taken note of all the questions and the chat box comments, which we will put it together in our report. And friends, we have to take forward this agenda. I would really enthuse the various institutions and different states to please start holding these annual events on HRH in your different states, and your institutions should take this forward. And before we end today's this webinar, we would like to, and before I request my Sutradhar, Dr. Ruchi and Dr. Vandana, to come again and propose a vote of thanks, Eco India, who has been our huge support in holding our virtual symposiums and webinars, would like to give you a brief on their activities. Over to you, Dr. Bhalla, and
Thank
if
you.
you can be very brief.
Thank you, ma'am. First of all, really, it's really an eye-opener, this webinar, I must say. That,
1 second, yeah. Yes, Dr. Bhalla.
Yeah, first of all, it's a great eye-opener, this webinar. I must say the top-notch leaders, those who have been the part of this webinar, it's really a great thing that the webinar on achieving universal health coverage by strengthening human resources for health in India, the topic has been chosen. And I think the few points which I also want to highlight, that World Health Organization views universal health coverage as a key to ensuring health and well-being of all people and all ages, and made it fundamental objective for all countries for attaining equitable and sustainable health outcomes. Most importantly, better governmental stewardship for creating strong and resilient health system, which madam you have also highlighted is required. A whole of the government approach that must target all social determinants of health and emergency investment in healthcare research and innovation. We, on behalf of Eco India, we are really thankful to all the leadership here, and specifically Dr. Professor Harshad Thakur, the director of NHFW, Dr. Rajni Bagga, the madam who has led this initiative, along with Dr. Vandana and Dr. Ruchi, and all the stalwarts, Major General Kotwal, Professor Harshad Thakur, Professor MC Mishra, Professor Keshi Nath Reddy, Professor Venkat, Dr. Manju. I think we are really grateful that the ECO platform has been taken it up in this initiative, and ECO is basically extension for community health outcome. This is an organization, not for profit, set up in India to help in a way that how capacity building can play a role to provide the reach and scale with the major 4 principles, that is amplification of the resources by using the technology, sharing the best case evidence-based practices, case-based learning, and using monitoring and evaluation techniques also. So we, on behalf of Eco India, really thankful to all of you for giving this opportunity to us. Wishing you all very, very fruitful journey, and specifically Dr. Rajni Bagga ma'am, your greatness and your commitment to the work is going to get what we are all today. So all the best for your all future endeavors also. We are always with you, and with your help only, we got a great engagement with NHFW, which I can never forget. On behalf of my leadership, Colonel Kumudrai and Dr. Sunil Anand, all the best, stay safe, stay healthy. Thank you.
Now over to Dr. Ruchi.
Thank you, ma'am. It gives me immense pleasure to present the vote of thanks for today's webinar. I take this opportunity to thank our respected chief guest, Major General Professor Atul Kotwal, our guest of honor, Luigi Daquino, for attending this webinar despite the busy schedule. Thank you so much. I extend my gratitude to our director, Professor Harshad Thakur, without whose initiative this program was not possible. Thank you, sir, for giving us this opportunity. It is my pleasure to thank all the eminent speakers for joining this webinar and giving us the valuable insights. I sincerely thank all our professors, research staff, and colleagues for glorifying this webinar. I thank our IT partner, Eco India, who helped us getting connected with everyone. Thank you all the participants for joining us and making this event successful. I hope you all had a wonderful learning experience. Last but not the least, I would like to thank our report writing and organizing team for enthusiastically arranging this webinar. Without you, this webinar would not have been a success. Thank you all. Wish you all a wonderful weekend. Be well, be safe. Thank you.
Thank you. Thank you so much. Thank you, everybody. Thank you. We really appreciate this. And let us continue the journey of strengthening human resources in health. Thank you.
Thank you, ma'am.
Thank you, Albin. Thanks a lot for your support. We really appreciate it.
Thank you, everyone. Yes, Onish, you can close.